I think the key message is AMR is everybody business, and addressing AMR could really help us to strengthen the overall health security.
I grew up in a place where pharmacies were the first stop when you felt unwell, not because it was cheaper or faster, though it often was, but because pharmacies had become part of how people navigated everyday health problems: fever, cough, infections, uncertainty. You describe your symptoms, someone behind the counter hands you antibiotics, and you hope for the best. Drive an hour outside the city and the equation changes. In rural areas, antibiotics are not just medical tools, they are economic ones. They keep chickens alive and goats healthy and cattle productive. When animals are income, antibiotics become insurance. They are part of the household risk calculations that farmers make every day. Travel a few thousand kilometers from there, and the logic is different again. In London or New York, antibiotics are wrapped inside clinics and telehealth and GP appointments. But a familiar instinct remains: fight the infection first, ask questions later. Different words, different reasons, same category of behavior. And this is where antimicrobial resistance starts to become interesting, not as a scientific idea or a laboratory term, but as something woven into everyday decisions. I didn't start out thinking about antimicrobial resistance this way. For a long time, I saw it as a hospital problem, a specialist concern, something about superbugs and hospitals and surgical wards and scientists in white coats. It felt technical, remote, and slightly doomish. But then I started paying attention to how antibiotics actually move through daily life. And once you see that, you can't unsee it. You notice that antibiotics behave a bit like household currency. People spend them when they are worried, when they are busy, when they are sick, and when waiting feels risky. And microbes respond to this spending. They adapt, they reorganize, they evolve. Which is when I began to understand why so many experts now say antimicrobial resistance is everybody's business. I wanted to know what they really meant, especially in Africa, where antibiotics sit at the crossroads of access, behavior, agriculture, and health systems. But also globally, because this isn't just an African story. Telehealth prescribing in the US, leftover antibiotics in Europe, and poultry production in Asia and Africa all feed into the same microbial negotiation. And microbes do not carry passports. So I spoke with Dr. Yahya Ali Ahmed at the World Health Organization's Regional Office for Africa. WHO Afro works with 47 countries across the continent on antimicrobial resistance. They see the systems inside the behavior and the behaviors inside the systems. And they've been building a continental response long before antimicrobial resistance became a global headline. When I asked him about how serious antimicrobial resistance is, he didn't hesitate.
Normally, the data show that AMR is associated with almost 5 million deaths at global level, but it is directly linked with over 1 million deaths every year. So unfortunately, in our region, we have the big burden because AMR could cause associated with over 1 million deaths every year, and it is directly linked to 250,000 deaths every year. So this is really very important number. So that is how big is the AMR. So it's really need collective approach to address this burden.
That number, 5 million, surprised me because most of the public debate about antimicrobial resistance lives in the future. Headlines about 2050 projections and 10 million deaths, but the present burden is already enormous and it's not even evenly distributed. African countries face a bigger share of severe bacterial infections, and in many places, access to antibiotics is both a blessing and a risk. People need access to survive infections, but the way antibiotics are used and the systems through which they are delivered shape how fast microbes learn to resist them. And here is the twist that changes everything. Most so-called misuse is actually rational inside the system where it happens. If doctors are scarce, pharmacies become the line. If doctors are scarce, pharmacies become the front line. If animals are income, antibiotics protect wealth. If telehealth makes it easy to get a prescription, convenience becomes a treatment pathway. If leftover pills are sitting in the cupboard, self-medication becomes logical. Once you see those incentives, antimicrobial resistance stops being a story about good and bad behavior and becomes a story about how systems shape decisions. Dr. Ali spends a lot of time working with African countries on precisely that systems question. He told me that every country in the African region now has a national action plan for antimicrobial resistance.
First at all, at WHO, we promote collaboration with some partners, FAO, OA, UNEP, in a way that this so-called regional quadripartite, we are working together to really harmonize our technical support to our member states so that they will be able to develop the national action plan to address AMR in the context of the One Health approach. And they use the Global Action Plan as a reference document to develop the national action plan. Once they have the plan with the support of WHO and other partners, now we are supporting them progressively to implement the plan, and we also conduct regular monitoring and evaluation. So every year we have a picture on how the countries are progressing in terms of implementation of the plan. This will allow us to identify not only progress but major gaps for further prioritization. And we have this opportunity that since 2023, our member states have adopted a resolution during the regional committee to really speed the process for the implementation of the national action plan. And we have indicators that we are following to see on how various member states are progressing so that we can better support them and prioritize their needs.
National action plans might not sound exciting, but in global health, they are like wiring a house before switching on the power. They define roles, priorities, financing, and responsibility. And they create something that matters a lot in antimicrobial resistance, which is accountability. Because antibiotics are not just medicines, they are coordination problems. They sit between human health, animal health, food systems, pharmacies, regulators, and communities. And no single sector can solve antimicrobial resistance alone. That is why the region has been leaning into what is called the One Health approach. One Health links human, animal, and environmental health. It recognizes that microbes don't care which ministry they are supposed to report to. This cross-sector collaboration is where Africa has quietly been doing some of the most interesting work. Not because the continent has unlimited resources, but because necessity often accelerates innovation. Pharmacies fill gaps in access. Veterinary tools fill gaps in agriculture. Communities fill gaps in information. And government fill gaps in coordination. But antimicrobial resistance isn't just about coordination. It is about enforcement. When antibiotics are sold over the counter without prescriptions or used in poultry without veterinary oversight, it accelerates resistance. I asked Dr. Ali how African countries are dealing with this regulatory puzzle.
Yes, this particular topic is really important. The regulation framework is very important because one among the critical element for the national action plan of our member state is really to optimize the use of antimicrobials, including antibiotics. So what we do is we support countries through the development of norms and standard as well as procedures. These allow countries to have better understanding, specifically health professionals, on how they will be able to ensure appropriate use of antimicrobials. This includes prescription. And outside of that, we enforce also regulation and legislation in a way that it will help member state while promoting access to antimicrobials, but it's made in a way that to avoid overuse or misuse of antimicrobials. Because in some countries, you can go to pharmacies and collect, for example, antibiotics without prescription by qualified professionals. So we encourage countries to implement those regulations, and we also conduct training so that they will align not only with the proposed laws and regulation, but also they will ensure appropriate use of antimicrobials.
That phrase, promote access while preventing misuse, feels like the entire antimicrobial resistance story condensed into 8 words. Because antibiotics are often incredibly valuable and incredibly fragile, too little access kills, too much access kills differently. Microbes don't care why antibiotics are used, only that they are. But regulation alone isn't enough. Cultures of health matter, and so do the economics of disease. If you've ever taken antibiotics just in case, or asked a doctor for them just to be safe, you already understand antimicrobial resistance behavioral economics, because uncertainty changes how we value antibiotics, and uncertainty isn't a uniquely African phenomenon. In the US, studies estimate that up to a third of outpatient antibiotic prescriptions are unnecessary. In Europe, leftover antibiotics are common, and self-medication happens quietly. In parts of Asia, poultry and aquaculture use antibiotics to stay productive. Different settings, same incentives. Microbes learn from all of them, which brings us to surveillance. Because if you can't see antimicrobial resistance, you can't respond to it. And if you can't measure it, you can't coordinate. This is where many African countries have been making progress, especially after COVID. Surveillance sounds technical, and in some ways it is, but it's also political. Because surveillance requires labs, and labs require funding, and funding requires priorities, and priorities requires leaders who see antimicrobial resistance as urgent. COVID changed some of that. Not because COVID was about antibiotics, but because COVID showed what happens when microbes move faster than our systems. And because COVID strengthened laboratories, surveillance networks, data systems, and public health capacity across Africa. COVID did something else for antimicrobial resistance that I didn't appreciate until I looked closer. It made the idea of health systems visible. Before COVID, most people didn't think about supply chains or PCR machines or surveillance networks or genomic sequencing. During COVID, those became household concepts. People talked about testing capacity, variants, labs, data, vaccines, logistics, and border controls. The public learned the vocabulary of health systems in real time. When I asked Dr. Ali whether COVID affected antimicrobial resistance work, he pointed to exactly this shift.
It is true that uh, addressing COVID has allowed member states to build to build the workforce, and it's allow also to have some equipment specifically at laboratory level, and was also an opportunity to strengthen infection and prevention measures. And what is important is member states need to ensure that integration of AMR interventions in the overall preparedness and response related to health securities, and why not integrating AMR in the overall health system strengthenings, because it could happen that in some countries, although there are significant progress made to address AMR, but still it could be left behind if there are other competing priorities, specifically in our continent where there are outbreaks, so AMR might be left behind. So this is where it's need a continuous advocacy, so that member state could implement appropriately the plan, knowing that we have been engaged during the regional committee, World Health Assembly, as well as UNGA, to consider AMR as priorities.
This idea, integrating antimicrobial resistance into health systems, is more important than it sounds. For years, antimicrobial resistance sat off to the side of mainstream public health, competing for attention with bigger, louder emergencies. Tuberculosis outbreaks, Ebola outbreaks, malaria surges, cholera, Lassa, Marburg. Africa deals with multiple microbial challenges at once. In that environment, antimicrobial resistance can become the quiet crisis, the one that kills cumulatively instead of spectacularly. But COVID pushed antimicrobial resistance out of that quiet corner, partly because the same laboratories and surveillance systems that track viruses can track resistant bacteria, and partly because COVID forced the world to confront what happens when a microbe outruns the health system. There's another layer here too, which is access. In many countries, antibiotics are part of how people navigate health uncertainty when doctors are scarce or expensive. During COVID, that uncertainty expanded globally. Telehealth prescriptions surged. People stockpiled medicines. Antibiotics were taken for viral symptoms, just in case. Even in wealthy systems, behavior followed familiar patterns. What makes African antimicrobial resistance work unexpectedly relevant to global antimicrobial futures? Because African countries have been operating in uncertainty long enough to build tools for it. Community-based care, pharmacy-first pathways, and agricultural antibiotic stewardship are not new. They are adaptations, and adaptations are useful models. Dr. Ali told me African countries are progressing differently on different parts of the antimicrobial resistance puzzle. Some are strong on collaboration, others on surveillance, others on One Health integration. He gave a few examples.
Countries are at a different level, and I may not be very holistic, but I could highlight, for example, there are some countries where they are progressing in terms of multi-sectoral collaboration. For example, Zimbabwe is an example where they ensure strong multi-sectoral collaboration, and also there are some countries that are conducting surveillance of antimicrobial resistance, and these countries might use as appropriate platform for WHO, and I could highlight Mauritius could be an example, and we could also mentioned about integrated surveillance, of which we need to promote sharing of information among human, animal, and environmental sectors. In this particular situation, Madagascar is also doing well. So there are various examples, and right now, for the World AMR Awareness Week, several countries are conducting various activities to sensitize communities and policymakers, such as Kenya, Togo, Cameroon, Zimbabwe, etc. So we have a good example of countries that are progressing, but somehow it is still important to move forward and to further sensitize countries to ensure adequate financing of their national action plans.
This isn't the way antimicrobial resistance is usually talked about in global media. We often hear about Africa through the lens of vulnerability, but antimicrobial resistance also has a lens of capability. And there are pockets of capability across the continent, some at national scale, some at institutional scale, some at laboratory scale, and some at farm scale. Some in the informal logic of how people care for themselves. And if antimicrobial resistance is everybody's business, then everybody has something to teach. But antimicrobial resistance also has a political economy. You can build plans, train labs, expand surveillance, and strengthen regulation. But eventually, someone has to pay for all of it. So I asked Dr. Ali about financing.
Countries that have already their national action plans, and we have developed a tool to allow countries to ensure appropriate costing and budgeting of their national action plans, and this approach allows them to further prioritize interventions and also to avoid some duplication of effort among various sectors, knowing the cross-cutting of AMR. So the budget might be different from various countries, but somehow what is important, we continue to support countries to ensure that the budget that are mentioned in the plan is done in a way that it will help them to further ensure advocacy and resource mobilization. Definitively, the financial crisis has a negative impact to properly support our member state. But somehow we encourage member states to have innovative approaches so that they could find some financial support in order to address AMR issues. We recognize that ownership of member state is very important, and having a national action plans, it's also support alignment so that all stakeholders, they will have clear idea on what are priority activities that they might need to focus more to ensure to address the need of our member state.
That word, domestic, is not accidental. It signals the shift from antimicrobial resistance as a donor-framed technical issue to antimicrobial resistance as a sovereign policy issue. And that matters for 2030 and 2035 because the microbial future will be shaped by countries that build their own antimicrobial resistance capacity, not just import it through grants and projects. Which brings us back to global antimicrobial resistance politics. In 2023, the United Nations held a high-level meeting on antimicrobial resistance. Countries committed to accelerating action, expanding surveillance, improving access to diagnostics, and coordinating through the One Health framework. This wasn't just symbolic. Antimicrobial resistance has now entered the same diplomatic era as climate, pandemic preparedness, and global development. Once a country reaches the level of political declarations, it becomes part of how countries think about sovereignty and security. And this is why the Africa global relationship gets interesting. Because Africa is not just a site of burden, it is a site of experimentation, and experimentation produces insight. For example, African countries have more experience with pharmacy first care than almost anywhere else. That matters in a world where telehealth is normalizing pharmacy-like behavior in wealthy countries. African poultry systems have been managing antibiotic pressures for years. That matters in a world where global poultry consumption is still rising. African laboratories have been scaling under uncertainty. That matters in a world where uncertainty is becoming standard. And African public health institutions have been operating in a landscape of multiple microbial threats at once, which is exactly the landscape antimicrobial resistance creates globally. If you want to understand the microbial future, you can't only look at rich countries with stable health systems. You also have to look at places where microbes and people negotiate more visibly. But to get to that future, countries need more than behavior change and political declarations. They need data. Data makes antimicrobial resistance visible. Data makes antimicrobial resistance governable. Data makes antimicrobial resistance negotiable. COVID made data normal. COVID also made supply chains visible, diagnostics visible, labs visible, and preparedness visible. If we can bring antimicrobial resistance into that same visibility space, we change the game, which raises the question, what does progress look like? Not in 2050, but in the nearer future, 2030 and 2035. For antimicrobial resistance, those are not distant horizons. They are within planning cycles, within funding cycles, within political cycles, and within microbial cycles. If antimicrobial resistance is everybody's business, then the horizon is everyone's responsibility. And responsibility is not abstract. It lives in decisions. The antibiotics people buy, the prescriptions doctors write, the animals farmers treat, the laws governments pass, the systems international agencies support, and the microbes that adapt to all of it. For a long time, antimicrobial resistance was treated as a kind of slow-moving storm, important but distant. Something for scientists, hospital administrators, and future policymakers. But the closer you look, the more the distinction between medical problem and everyday problem starts to dissolve. Antibiotics are not just hospital drugs. They are cultural objects. They are economic tools. They are part of how families navigate uncertainty. And microbes pay attention to how we use them. Dr. Ali reminded me that communities play a critical role in antimicrobial resistance, especially in Africa. Not because communities misuse antibiotics, but because communities make decisions inside the systems they have. Awareness is one side of the story. The other is infrastructure. You can't ask people to use antibiotics differently if the health system doesn't give them alternatives. Stewardship isn't just education. It is logistics, diagnostics, supply chains, regulation, financing, and trust. Without those, behavior fills the gaps, and behavior is not irrational. Most people do not wake up in the morning planning to misuse antibiotics. They wake up planning to solve problems. The problem might be a fever. It might be a sick child. It might be a coughing goat. It might be a chicken that represents next week's income. It might be a work schedule with no rooms for waiting rooms. It might be a healthcare system that is too far away, too expensive, too slow, or too uncertain. If we want to change antimicrobial resistance, we have to understand those problems and then build systems that solve them differently. One theme that surfaced repeatedly in my conversation with Dr. Ali was monitoring. Not the surveillance of microbes, though that matters enormously, but the monitoring of progress. Indicators sound bureaucratic, but in antimicrobial resistance, they are one of the few ways to measure truth. Not the truth of what is supposed to happen, but the truth of what is actually happening. Are laboratories seeing resistant infections? Are veterinarians changing prescribing habits? Are hospitals updating guidelines? Are farmers reducing prophylactic antibiotic use? Are governments funding antimicrobial resistance plans? Indicators turn speculations into accountability. Accountability also matters because antimicrobial resistance has no single hero. There is no vaccine that will solve it. No pill that microbes cannot eventually outmaneuver. No innovation that cancels the problem for everyone at once. Antimicrobial resistance is a coordination challenge. And coordination challenges reward the countries that learn to cooperate across systems. This is one of the reasons the Africa global conversation is shifting. There is growing recognition that antimicrobial resistance will not be solved by wealthy countries alone. Because microbes don't care about GDP, and because microbial evolution follows patterns of behavior, not borders. In wealthy countries, behavior is shaped by convenience, telehealth, and consumer expectations. In African countries, behavior is shaped by access, agriculture, and community level decision making. Different pathways, same microbial mathematics. I asked Dr. Ali what success looks like in the future, not perfection, but progress.
So our purpose is really first to really have at a country level a functional multi-sectoral collaboration, and this we need that at a country level there is a system so that there are strong collaboration, coordination of various sectors so that they will be able to address AMR through availability of joint terms of reference and joint plan to be able to implement the plan as well as to ensure sharing of information and transparencies between these different sectors. Our second approach also it is regarding the surveillance, because by having a good surveillance systems, this will allow them to detect AMR trends, and this could help them to update the guideline in terms of case management of patients. So surveillance is important, and also laboratory is a must, because without good laboratory systems, it makes difficult to ensure detection of AMR. And we could also say that regular awareness and education is needed, so we encourage member states to conduct this education for various stakeholders, including youth, communities across different sectors. And all this, we have indicators and we monitor those indicators, and this will allow us to see on how we can achieve the goals in a way that we hope to have a strong reduction of mortality due to AMR.
Mortality is a metric everyone pays attention to, but health security is the one that will shape the future. Health security is what countries care about when microbes change the rules faster than systems can respond. It is the difference between being surprised and being prepared, between reacting and managing. The United Nations has set 2030 as a landmark year for antimicrobial resistance action. Many antimicrobial resistance plans also project to 2035. Those are not science fiction timelines. They are within a single political generation. A child born today will be a teenager in 2035. Microbes will evolve many times between now and then. The question is whether our systems evolve too. This shift, bringing antimicrobial resistance into health security, may be the single most important narrative change underway. It moves antimicrobial resistance away from the margins and into the center of how countries think about their futures, especially countries that already know what it means to live with multiple microbial pressures at once. Africa understands that world. So does South Asia. So do parts of Latin America. Increasingly, so does Europe. And so will everyone else. Antimicrobial resistance is not a future crisis. It is a present reality, but it is also a solvable one. Not by eliminating microbes, that's impossible, but by learning to live with them intelligently. By using antibiotics the way we use other precious resources, which is carefully, collectively, and strategically. Which brings us back to the phrase that anchors this story. Antimicrobial is everybody's business. Not because everybody needs to read scientific papers or memorize bacterial species, but because everyone participates in the systems that shape antibiotics use. Pharmacists, parents, farmers, doctors, telehealth platforms, policymakers, veterinarians, pharmaceutical companies, ministries of health, ministries of agriculture, and the microbes themselves. If we treat antimicrobial resistance as a purely medical problem, we shrink our imagination. If we treat it as a behavioral problem, we blame individuals. If we treat it as a systems problem, we empower societies. And if we treat it as a global problem, with shared incentives and shared futures, we give ourselves a chance. Dr. Ali closed our conversation with a line that captures this shift better than I can.
I think the key message is AMR is everybody business, and addressing AMR could really help us to strengthen the overall health security as well as the ongoing effort of our member state to to address health system strengthening. So we need a stronger engagement of our communities so that they will play a critical role in the appropriate use of antimicrobials. So our health professionals need also to further implement critical activities based on the country's priorities so that they could support the ongoing effort on addressing AMR, and the policymakers, as they were engaged in the UNGA political declaration. So, monitoring some of the recommendation in the UNGA political declaration is really important, and the transparency of sharing of information is also important.
Commitment is not trivial. Commitment is how systems change. 2030 is not far. 2035 is not distant. The question is not whether microbes will evolve. They will. The question is whether our systems, our behaviors, and our politics will evolve faster enough to keep up. If antimicrobial resistance is everybody's business, then the future of antibiotics depends on all of us. Not just in hospitals, not just in ministries, not just in laboratories, but everywhere antibiotics are used and everywhere microbes pay attention. And microbes always pay attention.